November the 1st, 2022, join us at the Conference on Dermatology and Cosmetology in Qatar. Under the theme, Recent Advancement, Changing the Future of Dermatology and Skincare. This one-day conference will feature a wide range of topics that will discuss the latest developments and findings on dermatology, natural cosmetics market and skincare, and will include interactive sessions like panel discussions, presentations, workshops, and the opportunity to network with other dermatology specialists and practitioners across the globe. What are you waiting for? Join us on our exclusive all-in-one virtual platform and register now in our website.
Welcome back everyone. Let us move to the next session, Innovations in Dermatology, and introduce our speaker for this session. Dr. Ali Swaid, Consultant Aesthetic and Reconstructive Plastic Surgeon in London and Qatar. Dr. Ali has been a United Kingdom General Medical Council certified plastic surgeon since 2014. He graduated with the medical degrees from the Royal College of Surgeons in Ireland. He initially underwent general surgery training, leading to his membership in the Royal College of Surgeons of Edinburgh, MRCS. He subsequently continued his specialization in plastic surgery, earning his fellowship at the Royal College of Surgeons of England. He has completed distinguished fellowships in burn surgery, reconstructive microsurgery, and major trauma surgery, and 2 aesthetic surgery fellowships from the United Kingdom and Brazil. Dr. Swaid practices as a consultant aesthetic plastic surgeon in the United Kingdom, Qatar, and Lebanon. Welcome, Dr. Ali. The platform is yours to present.
Hello, everybody. Can you just confirm you can hear me okay?
Yes, we can hear you, Dr. Ali. You can proceed.
Fantastic. Thank you. So we chose a topic today of recent trends in cosmetic medicine and surgery. I chose it because especially working in different countries, we find that there's trends among these different countries, but recently this year, there's been a lot of advances and requests for things that not are traditionally done in our field, whether it's cosmetic practice in dermatology or plastic surgery or any practice that we do. And there are requests that are not things that normally would have been trained in many, many years ago, and we're having to evolve with the patient's requests. So I thought something to talk about, mainly about their potential, because these new trends do have potential, but there's also pitfalls, and there's things we need to look out for. I'll start off with body fillers. Body fillers are probably one of the latest things that have been introduced. They've got a lot of potential, especially for those who don't have enough body fat. I'm seeing increasingly patients who want augmentation of the body. We're not talking about the face, we're talking about the body, like the buttocks, the hips, and so on. But they are too slim to have body fat, and they don't want implants, or implants are contraindicated. Of course, they've got no anesthesia requirement, there's no additional scars, there's no downtime, no surgical risks associated with surgery, like taking fat off somewhere else, or the implant risks. And they're also helpful after surgery to improve irregularities after surgery. Now, they do have pitfalls, and the pitfalls mainly revolve around granulomas, because they are also about lumps, about resorption. However, those who do buttock fat injections, who are surgeons, would know that there is risk with fat injection. And this is extremely minimized when people are consulting for body fillers. However, it's not minimized at all. The risk of fat embolism still exists. And without knowledge of anatomy, they can be extremely dangerous procedures. And they can lead to strokes if injected in the wrong place. So body fillers do have potentially a role in an aesthetic practice. The main concern is the push that the marketing companies are pushing for, because it opens a market for them suddenly to a bigger market. But they do have risks, and one should be very, very careful when using them, and really in limited cases, if at all. Now, next thing we talk about is skin boosters. And skin boosters have got a resurgence, actually. Of course, the original skin booster was by Restylane many years ago, but in recent times, there have been more skin boosters on the market. I'm trying to avoid using, of course, brand names, because I don't want to be associated with any brand. And I do think that skin boosters do have a potential in this age. I think now the patients are requesting less and less more the fillers and the augmented look that were popular perhaps 10 years ago or 5 years ago, and they want very, very natural results. And the skin boosters, this is where they fit in. And at the same time, PRP is getting outdated and patients not seeing the effects that they want. So they will give skin hydration, skin tightening. They do have a higher concentration of HA in them, and they grade to the lower face, which is usually a hard part of the face to treat with additional fillers and Botox without changing the shape of the face. So these do have a nice role in that part, I find, especially, and the neck, which is also quite a hard area to treat with normal fillers and with Botox. So this is the skin boost potential. However, we do have a slight concern with skin boosters if done incorrectly. And because they're injected quite in the dermis, in theory at least, there's a high risk of granuloma formation. And managing expectations, the patients would expect sometimes a facelift result with skin booster, or extreme hydration, or results that last a year. So they don't. And bruising, because you have to inject the whole face. And for people who want the downtime or don't want to have the downtime, perhaps they don't have a role. And they're painful. With the best techniques out there, they are still painful, and they won't be suitable for most patients. Stem cells, of course, they always come up with any cosmetic talk these days because of the potential they have. Of course, the traditional way of harvesting is from fat, and probably the best way of harvesting is from fat, and most reliable way. New technologies allow you to take them from skin, where it can be processed through a machine and extract the stem cells, but the evidence for that is extremely weak. An industry which is called stem cell in a bottle, but I think these are really not evidence-based at all. They're usually plant extracts or animal extracts, and they won't really work on a human. And we know that, yet still they're marketed as a benefit. And you'll find the ingredients with them, along with the stem cell, is other ingredients that actually do work. So they are really just not something that will indicate their injection to a patient. They're good for scars. People have scars. We see a great reduction if you inject fat, for example, or under a scar or on a scar. For hair loss, again, there are machines that can process fat to inject them into the hair, or now, recently, without using brand names, there are machines that extract skin and inject it back into the hair, and they do some promising results. And of course, for skin rejuvenation. However, again, it's about managing expectations. There is lack of evidence for a lot of things we are using stem cells for. Of course, they do work in some areas, but there is evidence that they don't work in other areas. They may be quite expensive because mainly the machines that you might use might be expensive, so the cost is high, or because people want to jump in on this opportunity. They can be, again, like unpredictable. Those of us who do PRP will know that. They might require another procedure or another scar to harvest tissue, because that's the best way to get good stem cells. And there have been reported cases mainly from spinal surgery, which has, of course, been used quite extensively because of the difficulty of that area of tumor formation. So they do have a small risk with them. And nose threads is one of the other things I've been seeing a lot of requests for. I put there with brackets that have potential. It's not really one of my favorite things to do, I have to say, because I've seen too many problems with them. But they can help to straighten the bridge of a nose quite quickly, perhaps lift the tip. It's, of course, an office procedure and with minimal downtime. They do have different risks to fillers. We all know about the risks of fillers, and we're scared every time we inject the nose. There are different risks. But I've seen a lot of problems with nose threads. They can cause skin necrosis. I've seen a few thread protrusions from clinics done somewhere else, and the thread comes out. About managing expectations, of course, they don't last as long as people think they last, especially with the tip, because the tip ends up falling down again very quickly. And they can create horrible scars in the nose. So doing corrective surgery later can be difficult, and they are painful. Cellulite, again, it's one of the most demanding topics that we would see, and it's got great potential because it's a very lucrative market. Everybody essentially has a bit of cellulite and who does not like it. And because it's so difficult to treat, there are people try a lot of treatments to get rid of it. Some treatments do work, and once they work, you can have very, very happy patients because it's a lot of suffered from for a long time. And usually the treatments can be quite straightforward for some patients. And when it works, it usually is permanent if they maintain massaging afterwards and good body shape and so on. And there are invasive and non-invasive treatments. We've all heard, for example, of some radiofrequency machines or probes that go under the skin. And recently now there are injectables with collagenase that will dissolve. And again, I'm just trying to avoid using brand names because I'm not associated with any of them. But there are pitfalls. The machines are very expensive and the return might not be so quick on them. There's variability of results, and assessment is very, very important for the cellulite treatment. And it's all about managing expectations. And some of these machines can cause injuries or deeper indentations like burns. IV therapies, it's a big boom of IV therapies now, mainly because they're not so regulated. So they have potential for, of course, for financial return, but also they, of course, will hydrate. I mean, there's essentially a bag of saline going through somebody, so they will feel better just from that point of view. And usually they give them some oxygen anyway, so the patient will feel better. Can they replenish vitamins and minerals? Perhaps, if they're very, very low. But we all know that taking vitamins and minerals is a very expensive way of making urine. But nevertheless, it is still out there. The pitfalls, they are invasive. At the end of the day, you will have to put a cannula to somebody, and that does carry a small risk of infection and extravasation and all this stuff. Of course, air embolism done by untrained people. And because it's a poorly regulated market, you will find untrained clinics that are providing them. The evidence for them is very, very weak, especially when you start entering into the skin lightening treatments and so on. And they can be dangerous because you're injecting calcium, magnesium, or other trace elements that in wrong quantities, they can be lethal. So they do have their pitfalls, and even though they can be done quite easily with a cannula, they want to be very, very careful when doing these treatments. And invasive skin lightening treatments, well, this skin tight, I call them invasive because the market promotes them as non-invasive, but they actually are invasive because there is a probe that goes under the skin. The beauty of them that they give immediate results, and they are a great supplement after surgery or during surgery because the skin will tighten straight away. However, this tightening is usually temporary and the skin will relax again and then retighten again. So they're great for Instagram photos, but in reality, the immediate tightening does not last as long as it does. But the skin will settle, of course, after any procedure with time. They're good for those with borderline surgeries and those with traditional devices don't work. And again, most of us who run an aesthetic practice will see many patients from other clinics coming saying, I've tried this device and this device and this device, which is radiofrequency or laser or whatever it might be, and they don't work. And a lot of these devices are not really working for patients as much as they would like to. and got a little downtime. However, there are pitfalls, and it's quite a long list of pitfalls, and they are for the experienced hands. Skin burns, pigmentation, nerve damage, muscle damage, asymmetry, fat necrosis, seroma, all the stuff you'd expect with a invasive treatment. And I insist on the word invasive because they are invasive. And do not tackle the deeper tissues or issues that might be leading to this. Buccal fat removal, I think every other day I get a request for buccal fat removal. It's good for improving the contour of the face in certain people, but it requires a very, very careful assessment of the face. Not everybody should have a buccal fat removal. It might not suit their face. It can be quite straightforward in experienced hands and can be done in the office, but they can be very tricky also. We get an immediate result and usually a permanent result. However, it has pitfalls, and we've all perhaps heard stories of parotid duct injuries. Hollowness is one of the biggest risks because the buccal fat pad does extend into the temple, and removing too much can give hollowness in the temple and the buccal fat if one's being very aggressive. Asymmetries, and they are not reversible unless you go back injecting fat in. So they are usually a long-term procedure. Again, dimpleplasty is a very, very popular request, especially this year. It does give a good aesthetic look for some patients. It can be a very simple procedure and office-based, and potentially it is reversible. But we'll come to that in a minute because also I would say it can be irreversible. If the scarring is quite bad, then you need surgery to release the scarring to return the cheek how it was if possible. They will not last, and usually a lot of the people who do have especially with the suture technique that is without dissection, the results will not last beyond the suture dissolving period. They can be overdone, and asymmetry, of course, is a risk, and might damage the facial nerve and the parotid duct. Okay, and quite important to manage patient expectations, and because they are overcorrected in the first instance, patients might not like the look they have for a while until it settles down, and that might be disappointing if that's what's explained to them from the beginning. Lip lift, it can be great to reduce the lip length, and some people do have a long lip length. It can give the appearance of an augmented lip, and for those who do not want fillers repeatedly, it can be a solution for them, especially if they have quite a long distance between the vermilion border and the base of the nose. It is permanent. The scar can be hidden if done well, and if, of course, with makeup, and they're good for reshaping the lip, especially again for those who want a central lip that's quite high. However, scarring can be horrible if done badly. It can expose the mucosa of the mouth, and that can lead for a period of time at least until the mucosa adapts of dryness of the mouth, and it can cause lip dryness as well. If overdone, it might be difficult to close the mouth, of course, so that's a disaster. And it can expose the teeth when the mouth is in a static position. That's perhaps not the look the patient might want. So again, this should be cancelled as part of the treatment. All right, so we're done. Any questions?
Thank you, Dr. Ali. So let's start now with the first question. What do you foresee as the trends for 2023?
I think for 2023, there is a few things that are coming in. I think certainly cellulite treatments is one of the things that are most advancing in, especially with now the approval of some collagenous injections for cellulite. So we would expect more treatments, more injectables for cellulite treatments coming on the market, and more skin tightening devices that are invasive, because the market now is dominated by one machine. And there are new machines coming in the market that will probably just that competition. So I think there's two things that are probably increasing in demand and for next year.
Second question, what is the most effective way to treat cellulite?
I think still the most effective way to treat cellulite is through some sort of invasive procedure with a device that can cut the bands. Still, injectables have got a good potential to some cellulites, but still the invasive way is the best way. And there are new machines now with more controlled cutting than the older ones. I would mention, for example, Aveli, which is a nice machine to treat cellulite. It's more controlled than the previous generations of other brands.
Sir, the question, do vitamins influence work? Infusions work, sorry.
They work in terms of hydrating patients. I don't think they work for something like skin brightening and all that stuff. I do think patients who are deficient in vitamins, they might help them and trace elements, but this should be done in a controlled way by measuring the trace elements before and then replacing them. So from that point of view, it works, but that needs to be done then in a medical facility rather than through a beauty clinic.
Now, the fourth question and the last one, what is the difference between plastic surgery and cosmetic surgery?
Plastic surgery will cover cosmetic surgery by default, but plastic surgery goes a bit beyond than the cosmetic aspect, aesthetic aspect. A lot of the stuff we're using in aesthetics are transferable, for example, from reconstructive surgery and so on. While cosmetic surgery is more about, of course, the aesthetics of things. Some cosmetic surgeons might not be plastic surgeons as well. They could be specialized, for example, in ear, nose, and throat, or maxillofacial, or other specialties, yet they're doing stuff that is, people think of as being plastic surgery.
Thank you, Dr. Suwaid, for your knowledge and expertise. We move towards our next speaker of this session, Dr. Rima Hassoun, dermatologist at VLCC International, Qatar. Dr. Rima studied at the College of Human Medicine at the University of Aleppo and graduated in 2005. She obtained her master's degree in dermatology in Damascus in 2011, and since then she has continued her passion. She was a lecturer at the faculties of Human Medicine and Pharmacy at the University of Aleppo from 2006 to 2012. She obtained an attendance certificate from the Dermatology Department of Sisli Hamadiya Itfal Training and Research Hospital, Istanbul, 2017. She presented many medical programs on TRT Arabic and Syria TV between 2015 and 2019. She is also a member of the Syrian Society of Dermatology. Welcome, Dr. Rima. The platform is yours to present.
شكرا. مرحبا. سوري على التأخير. معكم دكتورة ريما حسون. اليوم رح نحكي عن مشاكل علاج الشعر. Here I am Dr. Rima Hassoun. I will my presentation about hair loss treatment with Regenera and plasma and mesotherapy. Dr. Rima Hassoun, dermatologist, VLCC International, Qatar. I want to share with you a video from Istanbul to Doha. What is the Regenera Activia? Three-step process of for collecting three between 3 and 4 small tissue. And we take between 3 or 4 biopsy from around the hairline behind the hair, and we put in cone, then in Regenera. I photo video to see how to do Regenera. Here we have stem for see the follicular. Here's the tools. We remove the hair from here, we chip the hair, and we cutting biopsy from this area. Here we put anesthetic. For that, patients don't feel any pain when we take the tissue. Sometimes we take 4 or 5 biopsy. Here we add serum, then we rotation in the machine to mix them. 2 minutes. Then we put in injection. Then we start to injection for the scalp. Here we have the type of hair used. Sometimes the patient ask us how many sessions are required for Regenera Activia. We need one every 1 year or 1.5 year. How long the expected time until results become visible? It takes time between 1 month to 2 months. But when I do in my clinic, there is 4 patients. The results come after 2 weeks, just 4 patients. Most of patients, the results come after 5 weeks. 5 weeks. Are results permanent? No. The patient needs every year or year need more need 1 year. This for transplantation to convert, but I want to start with Regenera to talk about that. Regenera Activia uses the AMT autologous micrograft technology, which is an innovative, simple, and effective regenerative method capable obtaining autologous micrograft using Regenera technology. AMT protocols are based on stimulating cell regenerations by activating native progenitor cells located in the homologous tissue through a simple process without risk to the patient and with great therapeutic potential. Here I want to share this photo to see the puncture 2.5 millimeter. We take this area from outside the skin to the whole thickness, epidermal, dermis, subcutaneous tissue, all this in the biopsy. In a single session, the patient is a donor and recipient of autologous micrograft, allowing recipient area to benefit from the regenerative activity of the progenitor cells and the growth factor extracted from the donor site. The technique is based on clinical studies that show there is a high concentration of the progenitor cells obtained in solid tissue. Through a calibrated mechanical cutting process and filtering cells and other resource elements are concentrated. Here we have alopecia microscopy. Any one of them suitable to do Regenera. Here, this patient is ideal. This bad for Regenera, so we don't do this and this. We do this type, this two type. This patient is good, but not ideal also. 8 signs are very important. We take the number of hairs we use the trichoscope, and we see the distance between hairs, follicular miniaturization, hair diameter, miniaturized and non-miniaturized hair in the same follicular units, yellowish pigment, inflammation in the hair, scalp general condition. All of this 8 signs, very important to choose the patient with the Regenera. Micrografts are obtained quickly, safely, and standardized through automation, mechanical disaggregation, and solid tissue filtration. The Regenera kit is CE, FDA, and FMA certificate. The area we take tissue from is here, in the back of the ear, in the hairline, hair implantation line. Why we take this area? Because we need area covered from the sun, have more vascular. this area very suitable for take tissue from this area. Also, androgenic alopecia. This procedure is characterized by three phases. First, extraction of tissue from the patient. Second, disaggregation of the tissue and the filtration of the micrograft solution. Then, application of the micrograft solution in the affected area by superficial subcutaneous infiltration. The first results are observed between 30 to 90 days after the procedure. That depends on the patient. Micrografts contain a high percentage of progenitor cells, which are key in the regeneration, revascularization, and the growth hair. Also, we can share Regenera after 1 week with the BRB to injection here if patient suitable to take blood from him and don't have chronic disease. Then we injection BRB. Also, we can share with mesotherapy. This slide we see about. I want to share with you this photo when we take biopsy. Some patients I take 3 biopsy, some patient 4, some patient 5. That depends on the patient. If he can, if I can do more than 3 biopsy. This just a joking. Here we have the result after 30 days and a single session. This before, after. Here I want to share a video with you when we do Regenera for patients. Of course, we take consent from the patient to photo him. This procedure not painful because we put anesthetic, local anesthetic injection. And before injection, I put cream also to patients don't feel any pain, also with injection. I take biopsy, then I press for healing. Here we, the Regenera, when we put the solution. Here we have the cone, we have barcode. The machine not work without this barcode. And work 1 time, then throw. We see the light, then we press to start. This is the tools. We prepare everything before we do the session. Here another patient. We take the biopsy. We take tissue. The size diameter 2.5 millimeter, not more. So no pain, no side effect. The time, short time, safe. We put here in the cone. Here we add BRB and ISO. Here where I work in VLCC company in Qatar. Sometimes doctor need to injection himself. Here I injection my. Here we do the Regenera to put in the cut to prepare for injection. And here, because we don't have time, here also to take biopsy. So, any question from you? Thank you for this conference. Thank you for allowing me to share my Regenera. I like for my patients because we have more results. We share Regenera with the BRB and plasma. Thank you. Any question? I wait. How many sessions? One session in the year. We need one session in the year or 1.5 year. No, not painful because we put anesthetic intradermal and then we do without painful. I don't prefer for chronic disease with diabetic also the peeling may be continuous. So I prefer to do for them mesotherapy without Regenera. How much the time of take biopsy? Between 5 minutes or less than that. The stress patient just 5 minutes. All that for as a video I put in the machine. Cost. The cost 12,000 Qatar riyal, but sometimes we have offer 7,500 riyal.
Thank you, Dr. Rima, for your knowledge and expertise. Moving towards our next session and calling up our first speaker of this session, Dr. Yazid Hassan Al-Shatri, Dermatology Department, College of Medicine, King Saud University. Dr. Yazid completed his MD from King Saud University, Riyadh, Saudi Arabia. He has worked with the head of the units. His passion is to learn and upgrade in the field of dermatology. Welcome, Dr. Yazid. The platform is yours to present.
Assalamu alaikum. Good evening, everyone. My name is Yazid Al-Shatri from King Saud University. And today I'm going to talk about case report of generalized morphea induced by COVID-19 vaccine in chronic urticaria patients. So our contents, we'll start by introduction, then we'll go for case report, then discussion, and conclusion. So COVID-19 vaccine induced autoimmune skin disease have already been reported through reporting of new case of such a disease and review of the literature. The current article attempts to facilitate the diagnosis of new cases of COVID-19 vaccine-induced autoimmune disease that may occur in the coming years after the pandemic has been contained. So this is the first case reported of severe chronic urticaria patient who developed new onset of generalized morphea following COVID-19 vaccination in the Kingdom of Saudi Arabia. So morphea, also known as localized scleroderma, is an inflammatory sclerotic change in the skin caused by idiopathic cause. Morphea diagnosis occur using the finding from skin biopsy and skin examination. We are reporting a case of biopsy-proven morphea after COVID-19 vaccine, where that patient developed diffuse skin lesions over all her body. The patient is known to have severe chronic urticaria and took 2 doses of Pfizer BioNTech COVID-19 vaccine. Duration between the first and the second dose about 20 days. The patient started to notice itchy lesions in her arms 2 months after the second dose. She is a 56 years old female with diabetic hypertension and bronchial asthma. She is also known case of chronic idiopathic urticaria since 2013. It is uncontrolled daily attack, more severe at night, usually take 30 minutes and resolve after she take antihistamine. It disrupts her sleep and she had history of angioedema that involved the eyelid. The current medication for urticaria are omalizumab and also chlorpheniramine and montelukast. On the 20th of February 2022 at follow-up clinic, the patient complained of new itchy lesions start in her arm, then involve the other area of the body. The lesions start 2 months after taking her second vaccine. There is no history of COVID-19 infection. She denied the following before onset of her cutaneous symptoms. There is no fever, chills, night sweat, rhinorrhea, also odynophagia, cough, noise of vomiting, arthritis, oral ulcer. And there is no rhinoid phenomena. And there is no any change in the weight. So skin examination revealed multiple liner atrophic hypopigmented and brown macules and patches over bilateral upper arms, as well as axilla, with a few sclerotic depigmented patches and plaques, and multiple well-defined irregular erythematous sclerotic plaques over bilateral thighs. Total BSA involved with the lesion around 45 of the body. Normal range was observed for CBC, chemistry panel, and coagulation, and functional test for liver, thyroid, and kidneys. There is normal limit were confirmed for ASR, C-reactive protein, ferritin, and complement C3 and C4 levels. The serology test shows positive for anti-nuclear antibodies. The rheumatoid factor was negative, hepatitis B and C are negative. We start the patient on phototherapy. She got photosensitivity from NBUFB exposure. Then she was started on topical steroid with methotrexate 15 milligram and also folic acid 5 milligram weekly. The patient still under follow-up and evaluation of response. As you can see here, there is multiple liner atrophic hypopigmented and brown macules and patches. Also here, you can see multiple well-defined irregular erythematous sclerotic plaques, both thighs. And here for the photo micrograph of skin bunch biopsy, it shows basket waves, keratin layer, epidermal atrophy with underlying thickening of collagen bundles. There is no atypical lymphocyte seen. So virus-induced inflammation has been hypothesized as the risk factor or underlying link between COVID-19 vaccination and generalized morphia, which activates the immune system or leads to cross-reaction of the virus and the host skin antigens. An evaluation was undertaken for the patient to measure level of autoimmune and rheumatological disease, autoimmune thyroiditis, hepatitis C and hepatitis B, and hemoglobin A, all of which were negative. So recent COVID-19 vaccine have been linked to some type of dermatological condition, including minor and critical ones. It is therefore important to consider these entities if a patient present with an exacerbation or new onset cutaneous. So this is our references. And this is the email of corresponding author, Dr. Rahim Dilatabi. Thank you, everyone. And now we can go for a question and answer session.
Thank you, Dr. Yazid. Now we will move to the question section. First question, what are the most common local reactions after COVID-19 vaccination?
The most common local reaction is induration, which is the thickening of the skin and hardness of it, and also erythema, which is the redness of the skin.
All right. Second question, what is the classification of cutaneous reaction following COVID-19 vaccine?
We classify it at 4 categories. Type 1, which is immediate hypersensitivity reaction. Also type 4, which is delay. And autoimmune, like with lupus. And reactivation of other infection like herpes zoster.
Okay. Third question and the last one, what are the other factors that have been implicated in pathophysiology of morphea?
We can, after so much research, there is factor like environmental, and also there is genetics factors like exposure to injuries, direct surgery, also radiation, and also the infections. Thank you.
Thank you, Dr. Yazid. It was a pleasure having you with us today. Now we would like to welcome our next speaker, Dr. Sonia Tekshandani, Consulting Dermatologist, Tender Skin International. Dr. Sonia is a faculty and author positions and authored 2 books titled Study of Clinical Cosmetology, a Hands-on Guide, Volume launched in February 2015 at Dermacon Mangalore, and Volume 2 in October 2016 at the Asian Dermatology Congress, Mumbai by renowned publishers JP Brothers. She is also the international faculty of the Indian Association of Dermatologists, Venereologists, and Leprologists, Cosmetic Dermatology Society of India, Asian Dermatology Congress, India and Japan. Dubai Derma, EADV Paris, Cosmetic Dermatology Singapore, Prime Bio USA. Dr. Sonia was also titled as one of the top 50 dermatologists in 2020 by Aesthetic Medicine India and featured top 30 Instagram influencer by Aesthetic Medicine India. Welcome, Dr. Sonia, and the platform is yours to present.
Thank you so much for that flattering introduction, dear. I will share my screen now. I hope I'm able to infuse some energy into...
You're welcome, Dr. Sonia.
Thank you so much. I hope I'm able to infuse some energy at the fag end of the day. It's a post-lunch session. I hope you have grabbed a cup of coffee to keep yourselves awake. I'll try to make it very short and hope you enjoy the session. Just give me a minute. So I'm going to talk to you on bioremodeling, a novel approach to anti-aging neck. I'm thankful to my assistant doctors who have helped me do the presentation as well. Next slide, please. So I would like to mention here that I have no conflict of interest. Whatever products are being described or demonstrated during this session are not endorsed by me. They are just for examples. So let's start with the learning objectives. What is bioremodeling? We need to understand what are bioaesthetic points, the injection technique that is into the deep dermis, evaluate the acceptance and the results of the procedure. So our aim is to check the efficacy of a bioremodeling filler for neck rejuvenation. Now, why do you think neck wrinkles have started to gain so much focus today? First of all, we are not extending skincare to the neck. It's an often neglected area. We often apply a sunscreen, moisturizers, retinols, all the anti-aging products on our face, but not on the neck or on our hands. And that's why you see the difference. The neck starts aging very quickly. Now, the other reason why you start seeing aging on the neck is because we are all now on digital platforms. We are craning our neck over our laptops and smartphones. And there are very, very limited options for neck rejuvenation. So we have like the energy-based devices, the radio frequency, the high-intensity focalized ultrasound. We have also something called as monothreads to address some amount of laxity of the neck. The botulinum toxin takes care of the platysmal bands. However, the creepiness of the neck is still not addressed. And hence, let's see what bioremodeling can do for your neck. So basically, with aging, we have seen there's a decrease in the hyaluronic acid, collagen, and elastin production. And therefore, you start losing the overall firmness and volume of the skin. So bioremodeling is a process that is triggered underneath the skin to create collagen and elastin. Now, this is basically when you inject hyaluronic acid into the skin, it boosts the production of hyaluronic acid, which in turn increases the collagen and elastin in the skin. Now, basically, this bioremodeling filler triggers the underneath skin to create more collagen and elastin, and therefore you start seeing anti-aging benefits as well as it addresses the fine lines, wrinkles, and creepiness of the neck. So this particular product has a combination of hyaluronic acid chains of different lengths and molecular weights, and this brings about regeneration through a synergistic mechanism called as bioremodeling. So how does it differ from the other skin boosters? We've been using skin boosters and we've seen the results. The first difference between the other skin boosters and the bioremodeling skin booster is the concentration of hyaluronic acid. So up till now, we've been using fillers which have a concentration of maximum 20 milligram of hyaluronic acid, whereas this particular filler has concentration of 64 milligram of hyaluronic acid. And that's how it enhances the collagen and elastin formation. superiorly to over the other skin booster. The second difference is, now this particular filler is injected through 10 bioaesthetic points only, whereas the other skin boosters are injected at multiple injections 1 centimeter apart. So of course, there's an ease of injection. The procedure is more comfortable, less painless as compared to the other treatments available. A little bit of history about this product. It was launched in 2015. It's basically an injectable containing non-cross-linked hyaluronic acid. As already mentioned, it contains 64 milligram of pure hyaluronic acid without any cross-linking. And it's the highest available concentration as compared to the other skin boosters with a maximum of 20 milligram. Let us see the injection technique. Now, it's basically a sequence of 5 injection sites on each side of your neck. Now, what was done was after the injection, a CT scan was done to find out the diffusion of the product. So the points which you see, these are in red, the injection points. And what you see is a zone of diffusion around each injection point, which is around 2.5 centimeter. So normally you see a zone of diffusion about a centimeter when you are using the other skin boosters. So this CT scan tells us about the diffusion of the product, which is very fast. It is quite fluid. Let's identify these 10 bioaesthetic points. So the first step starts with the marking of the neck. So the first midline indicator is draw a line from the chin to the sternal notch. And the lateral indicators are draw a line from the medial border of sternocleidomastoid to the sternal notch on both sides of the neck. Now let us see the points one by one. The first point is a midline point between the submental border and the hyoid bone. Let me take you to the next picture. This is the first point, that is the submental border, and this is the hyoid bone. The second point is midway between the apex of the Adam's apple and the thyroid cartilage. This is point number 2. Point number 3 is between the thyroid cartilage, bottom of the thyroid cartilage, and the sternal notch. And the fourth point is at the sternal notch itself. Now let us see the lateral points. Point number 5 and 6. Now this is a horizontal line which is drawn at the mandibular angle, and it is 0.5 centimeters lateral to the medial border of sternocleidomastoid. Now when you see point number 7 and 8, they are in line with point number 2, that is between the Adam's apple and the the thyroid cartilage. And point number 9 and 10 are in line with point number 3, that is between the bottom of the thyroid cartilage and the apex of the sternal notch. So every point you have to inject 0.2 ml of filler as a bolus into the deep dermal layer, that is the reticular dermis. Pinch the skin and then inject transversely across the skin. So since it's in the deep dermis, you have to inject at an angle of 30 degrees, or you may lie flat on the skin, but ensure that your bevel is 1/4 inside the skin while you're injecting it, and you should be able to see the silhouette of the needle. The protocol is 2 treatments at an interval of 1 month, which is usually sufficient to give you lasting results. After 2 treatment cycles, the results last for 6 months. Go to the previous one. Similarly, you can also do treatment for the face, you can do for the décolleté, you can do for the hands, you can also do for the saggy arms as well. So these are the bioaesthetic points of the face. This is point number 1. I won't be going into detail of this as we are talking about neck today. Now, when you are injecting, it's very important to ensure that you are deep dermal and avoid injecting the platysma. You have to consider these layers while injecting. You know, the neck skin is very, very thin. You have the skin Then you have the pre-platysmal fat, the platysma, and the subplatysmal fat. So whenever you're injecting the neck, you may easily go subplatysmal, which can lead to complications. So if you have injected the filler deep, the spreadability will be poor, and therefore the results will not be as evident as you would have done in the right plane. The other things what you're worried about is important structures in the neck. There may be injury to the vital subplatysmal structures like the external jugular vein, the carotid artery, the submandibular gland, the thyroid gland, the trachea and larynx. And fillers are known to give rise to vascular complications, even if it is a non-cross-linked filler. So you have to ensure that you do not inject into a vessel to prevent intravenous embolization and occlusion. So let us see what is the advantage of this bioaesthetic point technique, also called as BAP technique. First of all, the points of injection are reproducible. So in every client, you select the same points, you will see similar kind of results. It helps you to standardize the injection points irrespective of the variation between the patients. It ensures injection points to avoid injury to the potential vital structures, and it supports progressive diffusion across the widest sections in the deep dermis. And the maximum results can be achieved with fewer injectables and therefore more comfortable. The criteria for patient selection was patient had a creepy neck, not responding to conventional therapy like an energy-based device. We had already done radiofrequency, we have done high-intensity focalized ultrasound, we had done a botulinum toxin for her platysmal bands, and of course some botulinum, even a microbotulinum for her neck, monothreads to lift and tighten her skin. But over the last 6 months, she was not happy. The creepiness still persisted. And after 6 months, we took a call to inject this particular bioremodeling filler on her neck. Of course, prior to treatment, patient was provided with a complete medical questionnaire and detailed medical history was taken, and photographs were taken and kept as a part of medical record. So she was a 65-year-old female in good health condition, no known allergies, moderate skin aging. She had not undergone aesthetic procedures on the neck for the last 6 months. So whatever we had done was 6 months ago, but she still had a creepy neck in spite of doing all the treatments. So at the first session, 2 ml of bioremodeling filler was injected, and at day 30, second session was done. The bioremodeling filler was injected by the BAP technique, that is the bioaesthetic point technique. The 10 points were selected. As expected, you should see some small blebs which appear at the site of injection, which disappeared in 24 hours, and no complications or undesirable effects were seen. So patient found the procedure very acceptable and comfortable. On a 10-point scale, the satisfaction was rated as 8. In particular, creepiness of the skin improved. In a week's time, the client was quite happy with the results. The skin laxity improved, there was increase in elasticity, and there was good hydration altogether. Pictures were taken before and after at the end of the procedure. Pictures were also taken after a week, and the bioremodeling filler in particular suitable for patients with moderate to severe sagging. If there is too much of aging, then you can prefer to use a cannula and you can inject up to 4 ml of the filler. So in presence of hypertonic platysmal bands, you could also combine it with a botulinum toxin, but that's of course after a week. So 2 sessions were done. Patient was followed up for 6 months. The treatment efficacy was evaluated through aesthetic improvement, which was documented by clinical photographs and subjective satisfaction. Adverse effects like pain on injection, safety and efficacy were also documented subjectively. So these are some of the treatments. These are some of the photographs of the patient. This was what was her problem. There was creepiness of the neck. Her platysmal bands were quite visible, and you can also see some amount of laxity. This was at the end of first session, picture taken 1 week after the procedure. This is the procedure. Sorry, I'm not able to see this now. This was after 2 months, and the results lasted for 6 months. So you can see her platysmal bands are less visible. The creepiness of the neck has disappeared. The laxity has improved, and there's overall firming and tightening of the skin. This is an ongoing study. This is 1 session done and the picture taken after a week. So yet to document the result. This was a case presentation for a single client. So let's see what are the advantages of this procedure. Is it? Highest concentration of hyaluronic acid. Product has high manageability, comprises pure hyaluronic acid, no chemical agent. The molecular size is small. It's a lunchtime procedure. Only 2 sessions. All injections superficial and very safe. Side effects: temporary pain, redness, swelling, bruising. Lasted for 24 hours. Complications could be infection, reactivation of herpes, Tyndall effect, and vascular occlusions. Pre-treatment and post-treatment instructions: as with any filler procedures. Do not apply makeup for 24 hours. Avoid sauna, steam, and touching the rubbing the area. Massage of the treatment is not, do not massage the treated area. Yeah, so this is the product. I would like to show you a short demonstration if time permits.
We're starting with the profile markings. The midline marking, we take a line from the chin to the sternal notch over here. This is our sternal notch. This is our midline marking. The other one is give pressure on my hand. This is your sternocleidomastoid, the medial border. So we just take a line from the medial border of the sternocleidomastoid to the sternal notch. Similarly, on the other side, give pressure on my hand. Medial border.
It's time for question and answer, I guess. This is how the injection, this is the injection technique. So into the deep dermis, the needle is about almost parallel to the skin, angle of 10 to 30 degrees. The injection is about, the bevel is about 1/4 inside the skin, and you raise a bleb. This is the right way to inject the filler. Let's start with the question and answer.
Hello, Dr. Sonia. So let's start with the number 1 question. Will the bioremodeling help with lifting?
Yes, it does help with lifting. It helps to stimulate the production of hyaluronic acid, which boosts the production of collagen and elastin as well. Whereas the other skin boosters which we have used in the past, they do not stimulate production of elastin. And that's the important difference between the skin boosters available on the market and this one. And you've seen in the picture that there was a lifting of the neck.
Second question, what will happen if the filler is not placed in the right plane?
Yeah, so of course you can't get the desired results if you have gone deep, or it may lead to injury to important structures, and it could also lead to vascular occlusion like with any other filler.
Last question, can you give us some important tips for the best results?
First of all, you should know the bioaesthetic points. 2, you must inject the filler in the right plane. And 3, the post care is very important. You must extend your skin care to your neck. Applying a good anti-aging moisturizer and retinol is a non-negotiable ally. You have to continue using your home care, and of course use a good sunscreen, which is broad spectrum and also includes blue light filters.
Thank you, Dr. Sonia, for your expertise and knowledge. Moving towards our next speaker, Dr. Nalini Punir Mamadella, specialist dermatologist at Queen Dermatology Center. Dr. Nalini Punirma completed her MD DVL from Osmania Medical College, Hyderabad in 2010. She has 12 plus years of experience in clinical and cosmetic dermatology. She has also experience in India, Maldives, Oman, and Qatar. Her passion is to learn and upgrade in the field of dermatology and aesthetic medicine. Welcome, Dr. Nalini, and the platform is yours to present.
Hello, good afternoon, everyone. I'm happy to be a part of this conference. Hello, am I audible?
Yes, you are audible, Dr. Nalini.
Thank you. Yeah, today my topic of presentation is polycystic ovary syndrome, hirsutism, and acne, and its management. I chose this topic because I have seen many patients not unhappy, like even after doing several laser hair removal sessions, they are very unhappy that saying, doctor, we have changed many centers and we are not getting result. So when, because many places, what I noticed is the proper history and proper diagnosis was really not made, or the patient was just, thinking it's a cosmetic concern. So this made me like choose at least, the overall brush up of knowledge will help everyone. So coming to the polycystic ovary syndrome, it includes the symptoms of hyperandrogenism, presence of hyperandrogenemia, oligo or anovulation, and polycystic ovaries. It accounts for 80 to 90% of cases of hyperandrogenism in women. And the etiology of PCOS is unknown. It's a syndrome wherein multiple systems are affected and the site of the primary defect is unclear. Various lines of postulations suggest that there is a primary defect in the hypothalamic pituitary axis, resulting in the increased amplitude and frequency of pulsations of luteinizing hormone, and defect in the ovaries, and defect in the insulin sensitivity, resulting with insulin resistance, resulting in hyperinsulinemia. Pathogenesis of the disease is not fully understood. Coming to the classification, it's a proposed classification. There is mild PCOS, ovulatory PCOS, hyperandrogenism, and chronic anovulation, and severe PCOS, which accounts for 61% of affected women, and characterized by irregular periods, polycystic ovaries on ultrasound, elevated androgen concentrations, increased insulin concentrations, and potential long-term risks. These are the different diagnostic criteria of PCOS. And coming to natural course of PCOS, it may begin in utero. And in childhood, there may be rapid catch-up of growth, obesity, and premature puberty. In adolescence, there may be anovulatory symptoms, which typically begin at the time of puberty. And in younger women, may be difficult to distinguish from the irregular menses that often occur in the first year after menarche. Increased body mass index is a predictor of persistent anovulation. It has been suggested that all the three Rotterdam criteria, or at least both oligo-ovulation and hyperandrogenism, must be present to diagnose PCOS in a teenager. Infrequent or reduced menstrual bleeding or amenorrhea should be present for at least 2 years after menarche, or primary amenorrhea at age of 60. Common features of hyperandrogenism, like hirsutism affecting 60%, acne 20%, and scalp hair loss, irregular and infrequent periods, biochemical hyperandrogenemia should be present. In adulthood, infertility, cardiovascular dysfunction, and type 2 diabetes would be the presenting features. Hirsutism is a condition seen in women that is associated with development of androgen-dependent terminal hair following a male pattern distribution, that is face, chest, abdomen, and back. Hair in different areas of the body demonstrate varying levels of androgen sensitivity, depending mostly on local sensitivity of androgen receptors and 5-alpha reductase activity levels. Hair response to androgens vary from person to person and includes increasing follicle size, fiber diameter, and the amount of time spent in energy. That's the growth cycle phase of a hair follicle. It may be accompanied by even signs of virilization, like male pattern alopecia, deepening of the voice, clitoromegaly, increased muscle bulk. as well as moderately to severely elevated androgen levels. Evaluation of hirsutism is based on modified Ferriman Galway score, and the hair growth at each of the following 9 hormonally sensitive areas can be seen. And if the score is greater than 8, it's hirsutism. Female patient presenting with excess growth of hair, check the sites for excess growth of hair. If there is increased growth of hair in male pattern distribution, it could be the hirsutism. And if there is a generalized increase in growth of hair on all body, it's a hypertrichosis. And hirsutism, find the cause, take complete history, do physical and systemic examination. History of drugs, that's exogenous androgens. If we stop the drug and replace it with some other drug, and evaluate the patient on follow-up for the regression of hirsutism. If there are features of hyperandrogenism, then ask systemic hyperandrogenism, ask the rate of onset, like gradual onset with no virilization could be the PCOS or congenital adrenal hyperplasia. In case of rapid onset with virilization, the cause could be ovarian tumor or adrenal tumor. If there are no features of systemic hyperandrogenism, it could be idiopathic hirsutism. Acne is present in 15 to 25% of women with PCOS. It could be mild form, moderate, or severe form of acne. And acne is a non-specific feature, and severe acne persisting beyond adolescence may be more indicative of PCOS. And women presenting with acne and the signs of hirsutism should be evaluated for hormonal cause. And the diagnosis is based on the history and physical examination. And physical examination, look for the blood pressure and body mass index, along with also the signs of any hyperandrogenism and signs of hyperinsulinism, and thyroid examination for any enlargement of the nodule. Coming to the laboratory investigations, to rule out hyperandrogenism, do the total free testosterone and elevated total testosterone. If it is more than 200 nanogram, consider the ovarian or adrenal tumor, and serum sex hormone binding globulin may be decreased, and increased ratio of LH or FSH ratio may be present. If it's more than 3, suggest the PCOS. Lipid panel to rule out dyslipidemias. Fasting glucose to our oral GTT, ratio of fasting glucose to fasting insulin, and fasting insulin may be elevated, and these all tests to rule out the insulin resistance or type 2 diabetes. Prolactin should be checked to rule out prolactinomas. Thyroid function test, because hyper and hypothyroidism associated with menstrual irregularities. DHEA.
Dr. Nalini, can you hear me? If I may stop you, because we cannot see your presentation. Can you share it from your side? And if you are not able, we can share it from your side. And
sure. So, sorry about that. I think almost half of the presentation is done. So, okay, coming to ultrasonic criteria of polycystic ovaries. The transvaginal ultrasound is the preferred method. At least one of the following, that is 12 or more follicles measuring 2 to 9 mm in diameter, or increase ovarian volume. Do you want me to go ahead and show the slides, or shall I continue the presentation?
Yes, you can do quickly an overview if you have some.
Yes,
no problem.
I'm really extremely sorry for that, because I was not aware of it. And So the definitions, as already discussed, it includes the symptoms of hyperandrogenism, presence of hyperandrogenemia, oligo or anovulation, and polycystic ovaries. And etiology, as already discussed, it's unknown. Even the pathogenesis is not fully understood. And this is a classification and diagnostic criteria of PCOS. Natural course of PCOS, like we have to just go see, ask for the history to rule out, like if any child is present with premature puberty or in adolescence, anovulatory symptoms, and menstrual irregularities, and in women, any signs of hyperandrogenism, and in adulthood, infertility, cardiovascular dysfunction, and type 2 diabetes mellitus. This is a clinical picture wherein a patient might be having the multiple factors involved. And hirsutism, mainly we have to focus on the development of androgen-dependent hair, particularly in the male pattern distribution. And this is a modified Ferriman-Galway score, where we examine the 9 hormonally sensitive areas, and more than 8 is diagnosed as hirsutism. And already discussed, any patient presenting with increased hair, whether to rule out it's a hirsutism or hypertrichosis. So we have to check for the cause, complete history, and physical and systemic examination, and regarding the acne and acne hormonal evaluation, and history, and other features, like while taking history, we have to even focus on development, as the information regarding development of secondary sexual characteristics, and obesity, and family history as it relates to PCOS and diabetes, diet and exercise pattern, alcohol consumption and tobacco use. Physical examination, also check for the blood pressure, body mass index, and see for virilization and thyroid, as well as the laboratory investigations done to evaluate the hyperandrogenism, as well as the lipid profile to rule out dyslipidemias, and to rule out diabetes and impaired glucose tolerance. The test to be performed, and the thyroid function test to rule out hyper and hypothyroidism, and dehydroepiandrosterone sulfate to check for the assess the adrenal androgens. Then coming to ultrasonic criteria, to 12 or more follicles measuring 2 to 9 mm in diameter, or increased ovarian volume greater than 10 cubic centimeter in the follicular phase of the ovary. And transvaginal ultrasound is the preferred method. And in adolescent girls, the ovaries may be assessed by the transabdominal ultrasound. Only the measurement of ovarian volume is considered. Management, diet and exercise is very important, because a daily 500 to 1000 calorie deficit with 150 minutes of exercise per week can cause ovulation, and modest weight loss of 2 to 5% of total body weight can help restore ovulatory menstrual periods in obese patients with PCOS. Weight loss results in increased sex hormone binding globulin, decreased testosterone, decreased hair growth, and decreases the acne. Management of women with PCOS not desiring current fertility but with hyperandrogenic features. The first line of drugs is the oral contraceptive pills, and the second line is anti-androgen plus oral contraceptives. And to these, as an adjunct, the metformin can be prescribed. And the third line is the long-acting gonadotropin releasing hormone analog plus oral contraceptive pill. And to treat the hirsutism, we have to focus on the mechanical hair removal, or topical therapy, or laser-assisted hair removal. The primarily used the oral contraceptive pills are these, and they decrease the testosterone production predominantly from ovary. And oral contraceptive pills are more effective for acne than for the hirsutism. And also, they increase the hepatic production of sex hormone binding globulin and decrease the free testosterone. They should be used with the caution or avoided, particularly in women with risk factors like smoking, especially if aged greater than or equal to 35 years, and history of thromboembolism or migraine. And other reasons for caution include poorly controlled hypertension, diabetes, or of long duration, or with vascular complications. Metformin can be given as immediate release or extended release medication. And it is to avoid the gastrointestinal adverse effects. It should be given with food, and the dose titrated slowly over 4 to 6 weeks. Extended release metformin has a slightly lower incidence of gastrointestinal adverse effects. Anti-androgens, spironolactone 50 to 100 mg twice daily. This can be administered to it as an adjunct. Metformin can be given, or finasteride 5 mg orally once daily. And women with severe hirsutism or contraindications to hormonal contraception may be need to consider for treatment of anti-androgens. And anti-androgen should be used for at least 6 months before judging efficacy. The maximal effect on hirsutism may take 9 to 12 months compared with the effect on acne, which usually responds within 2 months. And in many cases, combination of anti-androgen and oral contraceptive may be needed, particularly for hirsutism or severe acne. The combination has added benefit of preventing pregnancy while increasing efficacy by targeting 2 different processes: androgen production and androgen action. Mechanical hair removal. like shaving, waxing, and epilation, but it is temporary. It is temporary benefit to the patient. And topical therapy like eflornithine, topical can be applied twice daily to the affected area, but it should be if there are no results seen, it can be discontinued by 4 to 6 months. And to destroy the terminal hair follicles, electrolysis is useful after or equal to more than 6 months of hormonal therapy has halted the appearance of new terminal hair. Laser and light-based technology for hair removal has become one of the fastest growing procedures in modern cosmetic dermatology in the last decade. Although long pulse ruby laser were among the first to be used, Alexandrite dyed and Nd:Arc lasers, as well as variety of broad spectrum intense pulse light sources are currently more commonly used for the treatment of unwanted hair. She's a patient, 33-year-old with hirsutism and acne, and she has been treated earlier by other clinics for topical medication and oral antibiotic for the acne. She was not responding to the treatment. And she was tried several home remedies, and when she was counseled and when her detailed history taken, and when all the investigations were performed, then she was referred to endocrinologist as well, and she was started on oral contraceptive pill and spironolactone 50 mg twice daily. Within 2 months, her acne responded well, and she got very good relief from acne. And just by she was using the topical benzoyl peroxide or sometimes just topical tretinool and oral medication of ocipals and spironolactone, she got a good response. And later she was started along with laser hair removal. And she's a 19-year-old girl, started for the laser hair removal and as well as on the dyeing and topical medication for acne. And after a couple of months, she's on follow-up. She's a lady. After 3 sessions of laser hair removal, she got very good relief. And finally, her psychologically, she became very happy because she was depressed. She was not attending any social gatherings. And she was taken detailed history, and on starting laser hair removal, she was very happy. And she's a lady with insulin resistance, with showing acne and acanthosis nigricans, algorithm for the PCOS management, and hirsutism and acne management. Patient discussions. Increased physical activity and healthy diet are indicated in women with PCOS. Women should be advised on the chronic nature of PCOS, and symptoms often recur if therapy is prematurely discontinued. It's a chronic condition, no cure. Management options are targeted at elevating the signs and symptoms to reduce the morbidity and prevent complications. Final point, the multidisciplinary approach is very important as for the best outcome of the patient, she has to be referred to the concerned specialist and counseled for the proper follow-up. Thank you. And time for question and answer. Sorry, I have taken extra time.
Thank you, Dr. Nalini. Let's start with the first question. When is the best time to test hormone levels?
The best time to test the hormone level in a spontaneous menstruating woman is 3 or 5 days of early follicular phase of the menstrual bleeding, or progesterone-induced cycle, early follicular phase, 3 to 5 days.
All right. Second question, what are the long-term complications of polycystic ovary syndrome?
Yeah, if polycystic ovarian syndrome can cause hypertension and diabetes, but gestational hypertension and diabetes in the pregnant women, and it can also cause the type 2 diabetes mellitus and cardiovascular problems, as well as in the long term, it can cause endometrial carcinoma. So it has to be properly evaluated early, and patient should be guided and properly referred to prevent the complications.
Sure. Third question, what is the important point to be mentioned to the patient with hirsutism planning to undergo laser hair removal?
As the hair growth in polycystic ovarian syndrome patient is hormonal, so the patient will be needing more number of sessions compared to the regular patient. as well as the patient also should be advised that she will be needing more maintenance sessions. So the long-term treatment is mandatory. So this has to be stressed to the patient, because otherwise they will be unhappy and they will leave the treatment in the early phase, which result in the recurrence of hair growth. Thank you. Yeah.
Next question. How do I know if it's time to see a doctor?
Mainly the patient, it's like a patient, they generally come to dermatologist for the problem of acne or excessive growth of hair. So it's like the acne is the main first concern to the patient, which make them come to a dermatologist, or the excess hair growth, that is the main concern. But when our responsibility is to take detailed history, because we know that what could be the cause. We can think like what could be the cause for the patient resulting in not responding. Patient is not responding to treatment, because acne can even start in the adolescence. It could be a normal presentation of the teenager, but if it's severe, along with other hyperandrogenic features and any family history of PCOS, and the patient is obese, and if she has to be taken thorough history and planned and treated accordingly.
All right. Last question, Dr. Nalini. Is there a new way to treat alopecia?
Yeah. Alopecia is particularly in the PCOS is the most common as the androgenic alopecia. So when we address the hormones by treatment, as well as we can give the topical minoxidil, which can be given like 2%, 1 ml twice daily, or 5%. But patient has to be used for a long time, because once they stop the topical medication, again the hair growth, the thinning will start.
Thank you, Dr. Nalini, for sharing your experience with us. We have now come to our last session of the day, Acne Updates, and would like to welcome our first speaker, Dr. Zahra Akbari, clinical dermatologist at Syrian American Medical Center. Dr. Zahra is a specialist in dermatology and cosmetology medicine and has done her graduation from the Tehran University of Medical Services. With more than 10 years of experience, she has conducted extensive research in new laser therapy methods for skin disease in various high-impact dermatology journals. Dr. Zahra has done multiple publications on acne scar treatment and laser therapy. Welcome, Dr. Zahra. The platform is yours to present.
Good afternoon.
Good afternoon, Dr. Zahra.
I don't have my own.
Yes, please, if you can share your presentation.
I'll share my presentation. Yes, please. Let me share my screen. Now it's okay? You can see my presentation?
Not yet.
Not yet. Huh? Sorry, I don't know what is the problem. I share my presentation. Yes. Now it's okay? You can see it or no?
Yes, I can see.
Okay. Bismillah ar-Rahman ar-Rahim. As you introduced, good afternoon to all my colleagues and our friends and professors. I'd like to introduce and discuss a bit about atrophic acne scars treatment. I'd like to have a small review and also updates regarding the newest and the latest technology and articles regarding the scar treatment after acne. As you know better than me, there is different types of acne scars, starting from rolling scars that is famous for shallow or sometimes deep depression on the skin without any edge, without any cut of edge. And also the fibrosing, anchoring fibrosing strands that tether the skin, pull down the skin to the fascia and stick to the fascia. The other type is ice-pick scar that is famous for the narrow opening and also the wedge shape deep seated into the skin into the deep dermis. And the third part is the boxcar scar that is famous for the sharp edge and the deep long wall with a square or other shapes that can be very shallow or very deep in the skin. It's important to know the different classification of acne scars, atrophic acne scars, but we should know that in most of patients referring to us, almost near to all of the patients, we have different types of scar at the same time. And even we cannot completely categorize each scar in one part. Sometimes we have ruling and box scar in one scar, or the mixture of ice pick and box scar in one scar. So we cannot completely classify one scar in one part. By the way, we want to talk just a little about each type of scar, the best treatment that we have for that scar. For sure, for ruling scar, as we have this tethered and this anchoring fiber that stick the bottom of the lesion to the deeper tissue, the best treatment is to release this strand. The subcision or subdermal incision. It is a type of procedure that we some device inside the skin, and then with some movement, the lateral movement and the forward and backward movement, we try to release this strand and let the skin return back to the previous side. And we have different devices to do this procedure, the subcision, starting from the no-core needle. In the right part of the photo, you can see the no-core needle, a gauge 18 needle with a sharp triangle tip. We insert this needle using a syringe lower lock or a METS, and then insert it parallel to the skin. We try to be parallel as much as possible. And then with a lateral movement, we try to release the strands under the skin to release the scar. But because of high amount of trauma and bleeding we have, the final results sometimes conflicted and complicated and sometimes we have hypertrophic noodle remaining from hematoma after this procedure by no-core needle. Recently, some doctors are using normal needle like gauge 18, like gauge 22 or 23. And we will see that they use it as the same shape of the needle, or they bend it 1 or 2 bending 90 degree and use lower lock needles, lower lock syringes and METS also to keep the needle much better. And then they enter and parallel movement and forward and backward movement and they make the releasing of strands. The very recent improvement and innovation is to use a cannula, blunt cannula in the treatment of and in the doing of subcision of acne scars. A blunt cannula can enter and without that much trauma that needle and no-core needle can release the sides, but because they are not that much strong, the new technique of blunt blade subcision has been evolved, and I'm honored to be in part of this innovation, blunt blade subcision, BSBB, that we had multiple articles over that. We use this blade tip to enter the skin and release the tissue rather than traumatic tearing of the tissue. We just shear the strands and there will be no effect and no trauma to the vessels and to the nerves. So you can enter just, for example, the line one, you can enter just from one point in the tragus and enter and do all subcision, all the skin. Before the subcision, to control the pain, we inject tumescent solution, and it makes it very good feeling for the patients during subcision. This article has been published in Dermatology Surgery Journal in 2016. The second types of scars that we have is ice-pick scar with a different depths that the most important parts of this scar is the narrow opening of the scar that makes it difficult to be reached by many types of lasers and fractional lasers. For example, you can see in this photo that I put one ice pick scar. You can see that sometimes the column of the fractional ablation can pass beyond the scar opening, so it has no effect on the scar. If we use a full ablative resurfacing, because we have lots of limitations to make it that much deep because of scar and side effect, unfortunately, the deeper part of this scar never touched and never improved. So this is recommended to do TCA cross method for this type of scar. And what is cross method? Cross is the chemical reconstruction of skin scar. We are using a TCA with high concentration for the treatment of this type of scar. In the first article published by Dr. Lee, he used 50% of concentration of TCA, but recently we are using 80 and 80+% of concentration of TCA using a sharp cotton-tipped applicator. We are putting exactly the TCA inside the scar, and we try to collapse and necrotize and collapse the wall of the scar, so it will collapse completely, and then the recollagen production, and so make it much better. The final result that you see, the final sign that you see that you are good in this procedure is you see that the white, very white, chalky frosting, the grade number 3 frosting with edema and erythema around the lesions that make you will be sure then that you did the TCA cross very well. Normally, TCA cross method should be done serially. Serially, I mean between 3 to 6 lesions at least within 1 month interval. It is very, very effective as of my experience, and we didn't see any side effect resulting from this TCA cross. Just whenever you do this TCA, you need to take care about the surrounding tissue, because as much as you put it exactly inside the scar and try to prevent it from the side, the surrounding skin, you will be more efficient and you will have less side effect. If you see, for example, in this histopathology examination after the cross in the right side, you can see how much collagen increased in the tissue that is published in our publications. The boxcar scars, as you see, it's very famous for cutting edge that it has, and the long wall that also it's deeply seated in the skin. It can be different with different depths, deep or shallow, and it's very difficult to improve, unfortunately, because of this sharp edge. One of the best treatment, I mean the choice of treatment that is offered for this scar is punch excision and punch grafting. As you see, we use an appropriate punch. We put it exactly, we go down to the scar and bring the graft up to the same level of the skin. Unfortunately, we have a little bit limitation for this punch excision and punch graft. First, because we cannot inject too much lidocaine, as it expands the tissue and it will interfere with the amount of punch that we use. The patients feel lots of pain. Second, when we are bringing this punch out, unfortunately, it will not steady state in the same level that we want, and sometimes it's up or lower than the state that we want will stay. So the cobblestoning of the tissue is the main problem that sometimes we have after this procedure. This is the reason altogether that the patients has most of the time referred by different types of acne scar at the same time, and makes a lot of doctors, physicians, and researchers to make a combination and to search about combination therapy. We believe that combination therapy means that to combine 2 or 3 procedures at the same time will let us to use the synergistic effects of this combination in one session to make higher effect So it will decrease the downtime, the total downtime that the patient needs for different sessions. Plus, it will decrease the length of time that we need to have the same amount of improvement. But which combination is the best combination to be used? There is different article. First of all, for example, a combination that is used in this article is a combination of three models. The first, they used the subcision. Then the day after, they used derma roller, and after 2 weeks, they used the 15% TCA full face peel. They got very good result. The second article is using subcision and the same session CO2 laser for the patients for 4 sessions, and they also get very good result. The other study used subcision and then deep microneedling, and they took very good result, and they believe that it's very inexpensive and very safe even for skin of color. And another split face clinical trial, they used subcision in one side at the same time, derma roller in the other side, cryo roller, and also they got very good result. Using human adipose tissue stem cell derived exosome just after fractional CO2 laser is another combination that they used, and they got very good result. And combination of subcision and human autologous fibroblast injection is also another very new project that in 2022 is published, and that they got very good results of human autologous fibroblast injection. Putting topical polylactic acid and then doing microneedling fractional radiofrequency is another combination that is used in the articles. And finally, what they used for the first time, they used CROSS, or chemical reconstruction of skin scar, and fractional non-ablative laser at the same session for 4 sessions, and they got very good result. Finally, what is my recommendation? What is my experience? In my experience, I like to use all these steps in one session. I like to use cross method TCA 80% for all types of scar, because I believe that this is even with the ruling scar, with a box scar, we have lots of atrophy of skin and epiderm that TCA 80% can help to improve the atrophy of the skin. At the same session, after doing TCA cross method, I use subcision, mainly for ruling and box scar. At the same time, I can inject derma collagen, derma filler, or collagen stimulator. Subcision that I'm using is most of the time a combination of different methods. I use blunt blade subcision, and over that, sometimes in single scar, I'm using a needle subcision or cannula subcision. In step 3, at the same session, I'm using a laser or light-based resurfacing. And because the patient during subcision got a very good anesthesia with tumescent solution injection, so during laser, we can go deeply and we can do resurfacing, full face resurfacing. And finally, over all parts, I will put the PRP or stem cell to make and be sure that the patient's treatment and the patient's repair is maximum. These are just some examples of one session treatment that you can see how much improvement we have after one session. For example, this patient, you can see the PIH of acne also improved, and also the pitted and scar. This patient, for example, the ice pick scar and ruling scar also both improved. In this patient, we have lots of box scar and ice pick scars that's improved in one session. Thank you so much, and I hope that this presentation find helpful and improve your knowledge about this acne scar treatment.
Thank you, Dr. Zahra. Let's start with the question. First question, when is the best time to start treatment of acne scar after isotretinoin therapy?
Look, before it was forbidden. When we return back to the documents and articles and everything, 20 years ago, it was forbidden to do any procedure within the 12 or sometimes 6 months after isotretinoin therapy. But recently we have a lot of articles that it is very safe even to do ablative procedures. So I myself had experience over patients that taking Roacutan or isotretinoin, and I see it is very safe even during isotretinoin therapy to do ablative procedures. So for me, there is and as lots of review articles recently published, I prefer to do it even during the treatment. Once I control the active acne, I started to do the procedure.
Second question, how safe is it to use 80% of TCA for skin of color patients?
This is a very good question because we afraid of using TCA 80% the skin of color, and not because of post-inflammatory hyperpigmentation, mostly because of post-inflammatory hypopigmentation. By the way, I used it because I'm living in Qatar and I'm doing this procedure for many patients with a skin of color. I see that it's very safe method. By the way, sometimes when I see that the patient's skin is very dark, like type 6, first I will test 1 point, and I prefer sometimes even to start with 50% salicylic, 50% TCA peeling. Then if the patients tolerate very well, the skin of patient tolerates very well, then going to the 80%.
Last question. Do you use full ablation for treatment of acne scars?
Sometimes, yes, I'm using full ablation, but there is limitations in the depths of full ablation that we can use because of the repairing problem. So most of the time when I'm using full ablation, I choose one part of the scars. For example, if there is any collection of the scar in one part, I will do 1 layer or 2 layer of full ablation with the medium depths, and then for the deeper depths collagen production, I will go 1 or 2 pass of the fractional ablative laser over this full ablation. This is the mechanism. I think it will be safe. You have the deep effect of the laser with fractional laser and the full face dermabrasion or full face resurfacing with laser at the same time.
Thank you, Dr. Zahra. It was a pleasure having you with us today. We would like to welcome our last speaker for the day, Dr. Raghda Barhoum, dermatologist at Platinum Medical Center. Dr. Barhoum graduated with a master's in dermatology and venereology from the University of Damascus, Syria. In addition to being a board-certified member in dermatology, venereology, and cosmetic medicine from the Syrian Commission for Medical Specialties, she specializes in skin care for any type of skin disease in adults and children. She is also recognized as an expert in dermatological surgery, cosmetic treatment, and all laser procedures. Welcome, Dr. Raghda. The platform is yours to present.
Okay.
We can hear you, Dr. Raghda. Go ahead.
Okay. Good afternoon, everybody. Sorry to be late. I start immediately now. So acne vulgaris is a common cutaneous disorder, clinical presentation of acne vary widely, ranging from minor skin involvement to extensive. Okay, I'm hearing my voice twice. Ranging from minor skin involvement to extensive presentation, chronic or recurrent development of papules, pustules, nodules in face, neck, trunk, or proximal upper extremities. Skin pigmentation may mask the characteristic erythema of inflamed lesion in patients with highly pigmented skin. Hyperpigmentation, scarring, and negative psychological effects are common complications. Next, please. Okay, reported prevalence of acne varies from 35 to over 90% of adolescents at some stage. The prevalence of acne decreases with increasing age. A survey of over 10,000 adults in the United States found the following rates of self-reported. You can see between 20 and 29 years, it's about half percentage. And if you go more than 30, it's 20 to 35. More than 30, it's about 12 to 26%. More than 50, it's 7 to 15. Next, please. Okay, here we see the modality, the pathogenesis for the acne, the microcomedones. This is a small hyperkeratosis plaque composite of corneocytes in the lower portion of the follicles. It considers the precursors of the clinical lesions of acne vulgaris, which include closed comedones, open comedones, inflammatory papules, pustules, and nodules. So procedures here, because of macrocomedones devolve the acne vulgaris, remains elucidated but may involve interaction informing pathogenic factors. Next, please, we will see that. Here we see the four main factors. It's the keratinization and the increase in sebum production by sebaceous glands, inflammation, and we have the Cutibacterium acne. Formerly, it was called Propionibacterium. It's the normal component of our skin flora, but also it's involved in acne vulgaris. Next, please. So we have now associated factors, the androgen and its effects on the sebaceous gland. Androgens stimulate function of sebaceous glands, increase sebum production, utilize triglycerides in sebum into pretty fatty acid and glycerol as a nutrition source. Androgenic production also occur within a sebaceous glands beside gonads, which convert dihydroepiandrosterone sulfate, the DHES, and adrenal androgen. They convert it to testosterone. Testosterone also, again, subsequently converted by 5-alpha dihydroandrosterone to type of 1-alpha 5-alpha reductase in the sebaceous glands. Now, the DHT, it's the subsequently from testosterone. This one has a great affinity to androgen receptors than testosterone, and it leads to the problem, the sebaceous glands and keratinocytes. So also androgen excess has happened in such cases like PCO or tumors or hyperplasia in adrenal. Next, please. Okay. We're following now in associated factors. We have genetics, more than threefold risk among individuals with affected first-degree family. We have insulin resistant, which is very important. We're gonna talk about it because insulin resistant because it increases androgen and also increase insulin-like growth factor IGF-1. According to academic reference center, DHES, DHT, and IGF-1, they are all correlative with acne lesions counts in women. Androstenedione and DHES in men. In women with acne, IGF-1 correlated with DHT. In men with acne, IGF-1 correlated with DHES. So we can see in both that IGF-1 is involved in both men and women. Next, please. Skin trauma, for sure, we all know because of scrubbing, soap, detergents, estrogens, because of promotion, comedones, and inflammatory lesions. We have stress. Stress cannot cause sebum production, but can affect on severity, especially in women. We know because we see this because of stress of work, examination, and interviews. For body mass index, BMI, it's here conflict because sometimes we see that under 18.5 increase acne and even more than 35, it's also increased acne in male and females as well. Diet, they found that mild milk consumption and high glycemia, they found that it's high carbs because it has IGF-1 and milk has components and natural components and biotic molecules and it's unknown how does it affect, but also low fat milk they don't know or we don't know if it helps. On the contrary. Next, please. In addition, dairy products, cheese, processed starch, soft drinks, saturated fat, omega-6, fast food, whey protein, all are accused. Low carbohydrate in may lead to acne improvement, low glycemia, low diet with metformin. Also, it has good improvement and also good improvement in metabolic parameters. Chocolate consumption increase acne, but it's unknown method. Also, we have seasonal variability because we can see that sometimes in cold weather, cold months, it's exacerbation on the acne, but warmer showing improvement. Psychological also, we've talked about it. Mechanical occlusion, headbands, shoulder pads, back pads, under wire bras. It's also aggravated. And for sunlight, excessive sunlight, also it's have both effect, improve or flare. Now, what do we see in the clinic? Typically, we've said before callosed comedons or open papulopustular lesions, nodular lesions. Rarely we can see cystic lesions. Sometimes we see erythema or PIH. Pro-adolescent patient also we see them. They have more T-zone comedonal acne. We have to assess them. We have to check. It's very important to talk about presence of scarring because it's effect on the treatment plan. It means that we have a severe case, even in with numerous papule or pustules. Next, please. International evidence. Acne more common in North American, homemade acne in African American, cyst in Mediterranean, darker skin type has a high risk for PIH. And there is a Swedish study published in 2017 explained that teenagers may have in the future with acne also, for sure, they may have prostate cancer. Next, please. Let's talk about post-adolescent acne. I would prefer to talk about it because I see it every day, daily, more frequent than any other acne vulgaris in my clinic. Common age is over 33, but it can happen for sure in less in between 25 and 33. In UK, there is 14% of women, they have post-adolescent acne between 26 and 44. It happens in lower face, upper neck and even trunk. Some acne vulgaris, same acne, same pathogens. Androgen also here, it has contributed because, why do we accuse the androgen? Because endogenously and exogenously, it derived increase in serum androgen levels to acne development in women. In addition, if we have see that anabolic steroid or testosterone supplement like progestin, also it causes this kind of acne, but the relationship still unknown. Next, please. Post-adolescence acne in women, the experts say divided. It's maybe acne for adult life or it's late onset acne. Late onset acne, that means that it's occurring first time after age 25. The two prerequisites of androgen expression and pilosebaceous unit are androgen in two forms, either testosterone or DHT, also receptor. So, combination between contraceptive and receptor blocker spironolactone, also cyproterone acetate flutamide, is required in treatment. Other response treatment is slow. We must encourage our patient to adhere to a chosen treatment plan, and also we have to do the maintenance. Next, please. Naturally, during premenstrual, we all see that it's premenstrual because sebum accumulate in sebaceous gland due to pilosebaceous oroface sizes reduction. It can have a role, but unknown because up to 83 women have premenstrual acne. Beside androgen, we have smoking, cosmetic products, pomade acne, and acne cosmetic. Nicotine increase sebum and keratinization, while cosmetic products, it's a plug. We can also add as a causes reasons. We have stress, diet, we have genetic factors, we have family history, no prior pregnancy, hirsutism, personal acne history, office work, low intake fruits, vegetables, and fish. Pregnancy effect vary, it's conflict, sometimes it's improved, sometimes it's worsened, sometimes it's unchanged. Next, please. Assessment, patient with this post-adolescent looking for SAHA or CHEA, sebum, acne, hirsutism, alopecia. Also, we look for, investigate our patient and ask our female patient about irregular menses, PCO, sudden onset acne, acanthosis nigricans, obesity, infertility, progestin. We should request for hyperandrogens even if it's not clinically obvious. And if the patient undergoing contraceptives, we let her cut them for 4 to 6 weeks, and then we do the blood test. The treatment is similar to the acne vulgaris. There is a skin routine, gentle cleanser, daily moisturizer, daily sunscreen. We have to tell the patient to avoid cosmetic oily products and replace them with oil-free liquid silicone, diaticone, or silicone matte foundation. We have to take in consideration here the therapies, the hormonal therapies, even in absence with the hyperandrogenism. Next, please. I talk about acne cosmetic because it also can similar comedogenic cosmetic products is the reason, but it's now less than before, and it's irritant reaction due to cosmetic products resemble to acne vulgaris lesion, also same papules, pustules, and occur within hours after application. Next, please. The acneiform eruption, it's like we have drug-induced. We have this calendar on the right side. We have monomorpheous inflammatory papular eruption. It's multiple disorder eruption and associated with true acne vulgaris. Next, please. Also, as a follow for the acne, we have pomade acne we talked about. It's because of oil products, oil hair products. We have acne mechanica. It's warm items such as shoulder pads or turtleneck or helmets. And we have acne exorist because of squeezing by patient. Next, please. We have a photo. Yes, next. Here is a photo also for acne exfoliation because of squeezing. Next, please. Most common consequences. This is very important to talk about scarring, PIH or PIE. PIH, post-inflammatory hypertension. It happens more in skin type 4-6. It's resolved spontaneously without a treatment, but may persist for several months. As a result, mild cases can exhibit by PIH, and it's disfiguring. That's why we need to treat it. PIH also and PIE, it's disfiguring and sometimes needs over a month for years. So also we need, but as we say, therapy. Next, please. Erythema scar, as we see, we should start scar erythema because it makes them more noticeable. The pulse dilator is a good choice for erythema scar targeting obviously hemoglobin. This session is between 3 or 4. According to the other dermatologist experience, KTP laser, IPL intensive pulse light can be effective, and fractional laser also it helps. Next, please. Now scarring, we can see here inflammatory scars results more the non-inflammatory, nodular and cyst presence and potential of scarring should be treated aggressively to prevent permanent sequels. Next, please. Achieving rapid control of active desire for patient evidence scar, similarly to cases with more severe acne, including early systemic therapy. So let's talk about the treatment here is minor surgical procedure, laser, chemical peeling that Dr. Zahra further mentioned, even injectable soft filler, microneedling. It was already talked about. Next, please. Evaluation, we have to do our assessment and evaluation, age of onset, if there is medical history, if there is family history, medication, skincare routine, psychological impact, if there are systemic symptoms involved. Also, we will see about children and young children or females if there is hirsutism and genital enlargement and deepening in voice. This is all considered. PIE, skin type 1 to 2, we talked about. Also, her treatment is PDL, fractional microneedling, topical 5% tranexamic acid, and IPL. Next, please. Assessment, acne severity, and the treatment. It's only that we can, we have choice to follow or not. It investigation, global assessment. It helps to follow up with the patient. Next, please. Okay, we have severe variation, acne fluminans and acne conglobata. It's extensive, it's nodular acne conjunctive with other features. Oral azithromycin is the first line here. For assessment, we have to look up type of lesion. What do we have, comedone or we have inflammatory mixed psychological effect? Is there any potential for scarring? If there is any failure or for previous treatment. Next, please. The treatment, it's including, it's a treatment maybe topical, over the counter that it's with patient don't need prescription and prescription. The patient seeking for treatment, we have to discuss with them treatment, and the patient often ask about impact of dietary change. Also, we have to discuss with them, help them to maximizing adherence treatment in general. At least any treatment plan we should wait 2-3 months and for adherence, and then we do reassessment. And then also I have to say that we, after these, if there is a good results, there is maintenance also long term with retinoid topical for 3 months. Next, please. Let's go next also, please. Okay, here example for therapeutic target. I will talk about it as follow in the calendar. Let's move to the next one. Yeah, we have topical, we have systemic, we have oral antibiotics and oral azithromycin and spironolactone and oral contraceptive. For oral antibiotics, maximum 3 months. There is concern for resistance, increase and upper respiratory infections, and if we treat the patient, we have doxycycline, minocycline replaced for tetracycline erythromycin in USA because it's better and good tolerability, and presence of the resistance here is less. Okay, next. Azithromycin, it's 500 milligram 1 to 3 times per week or 4 times per month, comparing with doxycycline. 100 milligram azithromycin has the same efficacy, both of them. Doxycycline, we have something called sub-antimicrobial dose. Sarecycline, it's new, but it unfortunately narrow spectrum antibiotic activity. It gives with weight, depending on weight. Okay, next please. This we have topical monotherapy, each one aside, and in the left to in the right we have the combination therapies. We can go to the next. Also we have guideline, we'll talk about it as follow. Let's go to the next one, the calendar. Okay, we start with mild act. Mild act, we need to start with topical treatment. Okay, let's talk about the calendar, it's important. First assessment, what do I have? Do I have acne scarring or disfiguring, post-inflammatory, the PIH, or I have psychological distress? Okay, if I have only comido, we start with topical retinoid for, let's say, 2-3 months. If there is a good result, we do maintenance, also retinoid for 3 months. If it's not good, we increase concentration with topical retinoid that we already prescribed, or we change to alternative retinoid. If it's good, also we go to maintenance for 3 months. Now, if I don't have only comedones, I have papulopustular lesions with comedones, we start with topical treatment, retinoid with benzoyl peroxide. If it's good for 3 months for sure, we do maintenance with topical treatment of retinoid for 3 months. If it's not good, we add clindamycin or topical dapsone, do reassessment after 3 months. If it's good, we do maintenance. If it's not, we do now replace them with minocycline or clascoterone. It's all topical. In conjunction, for sure, with the previous treatment, retinoid, benzoyl peroxide. So now we have retinoid, benzoyl peroxide, and topical antibiotics. If it's good, we do maintenance. If it's not, now we consider this case as moderate to severe case. Okay, now we will go to, I just need to mention this, that benzoyl peroxide can be used alone as an antimicrobial. In contrast, topical clindamycin should be used with benzoyl peroxide to reduce risk of resistance. But sometimes we have mild cases, more aggressive approach that refractory to topical therapy, so we go to systemic therapy. Okay, let's go to the next one. Now I have let's talk sample region. We shouldn't put benzoyl peroxide with retinoid because it affects on the efficacy of retinoid. So we tell the patient to wash the face, for example, with benzoyl peroxide cleanser. If we cannot, we tell to gentle cleanser and then apply benzoyl peroxide in the morning in the entire face. At night, facial gentle cleanser, then apply a little amount of retinoid for one layer on the entire face. Micronized retinoid 0.05% gel should be used in caution in patients with a non-allergy to fish because it has soluble fish protein. Okay, now let's talk about moderate acne. It's multiple body areas, and we have large inflamed papular and nodules more than 5 millimeter, many comedones, associated scarring. So here the first line oral antibiotics for maximum 3, maybe 4 months for resistance and appropriate topical treatment. Let's move to the next one. Okay, the calendar. Now we have severe cases. Severe cases, we start with isotretinoin. On the calendar, we can see what do I have? Do I have comedone as a moderate case, large area, multiple body area? I start with topical treatment we talked about with oral contraceptive or oral spironolactone or oral tetracycline. Tetracycline, no. Comedones, no, we don't use. If it's good, okay, if we do maintenance. If it's not, we can do contribution combination between spironolactone or also contraceptive. If it didn't work, we do assist after 3 months. If we say it didn't work, we will go to oral isotretinoin. To the left down, you see here if I have papulopustular with comedones as a moderate case or severe. Also, besides the topical treatment we give, here we should give the antibacterial. So we have tetracycline, doxycycline, minocycline, salicycline, or in female we can give contraceptive or spironolactone. Then we do assessment for 3 months. If it didn't work, we go to here. We have combination. We can combination with between them. Combination contraceptive spironolactone, contraceptive with tetracyclines, or spironolactone with tetracycline. Do assessment. If it didn't work, we go to isotretinoin. Let's go to the next. Oral isotretinoin, it's sebum production, it's effect on the bacteria, it's normalization of follicular epithelial desquamation. It is considered the only medication can permanently alter the natural course of acne vulgaris, long-term remission of therapy, and good choice when case is not severe. Even if it's not severe, but acne-induced scarring. So we start with isotretinoin. Psychological distress. Also, we can start with it. Moderated case. When other treatment has failed, we can also start. So its indication first line also in severe acne, gram-positive folliculitis, in severe acne rosacea, and acne fulminans, and pyoderma facial, and Fordyce disease, and hidradenitis suppurativa. Please, next. Okay, monitoring. We all do, as the dermatologist, the monitoring. Here we have to the right the side effect, but I will talk, please, about this study, that about what to ask for a blood test. Reduced monitoring now. Now there is a study said that we should reduce monitoring of liver function and lipid test in healthy patient receiving isotretinoin. Delphi consensus found that checking only ALT and triglyceride levels within 1 month prior and cause of the course and after reaching the peak, it's enough. This is the study I like to share with you. Let's move to the next. Okay, combination between the oral contraceptives, FDA approved on 4 of them. Progestin, when it's put progestin with ethinyl estradiol, the estrogen, it causes improvement in acne in unknown method. Case are effective in treating by relatively slow acting, taking as long as 3 cycles start showing effects. So we need 3 months to see effects with contraceptives. We should see side effect is cardiovascular and myocardial infarction, stroke, breast, cervical cancer. So better to avoid also smoker patient in this case, and also cardiovascular risk. Let's move to next. Next, I have calendar for contraceptive combination. Let's move to the next one. I have here, can see each one of the treatment, how does the effect on sebum production, comedone, and bacteria on inflammation. For sure, isotretinoin is the best. It affects on all. And mentioned that cyproterine acetate and oral contraceptive and spironolactone, the method is by sebum reproduction decreasing. Let's move to the next. Okay. Here, I think I don't have time, so I will go first to the treatment by light. Let's move to next one. If we have time, we can go back to here. It's about typical retinoids and alternative agents. Can we go further? Next. Okay, more next. Next, please. Okay, next. Yes, light-based adjunctive and other therapies of acne vulgaris. The benefits are limited. The efficacy is uncertain. What is the light-based adjunctive therapy for acne? It's a broad spectrum with visible light, blue light, red light. We have intense pulse light. We have laser, KTP, PDL, and infrared laser. We have photodynamic laser, photopneumatic technology. The mechanism is they are affecting of the Cutibacterium acne by something called preference. So it affects on this and it decreases. Red light activated also by but penetrate more deeply than the other one. The IPL and KTP laser may inhibit the bacteria and or damage sebaceous glands. Let's move to the next. Infrared radiofrequency photodynamic also damage the sebaceous glands and decrease sebum production. The photodynamic also reduce obstruction of follicles, hyperkeratosis, and inflammation lesions. There is a study said that blue-red light more effective than 5% benzoyl peroxide. An in vitro study said that laser targets sebaceous gland without damaging skin. Some trials suggest topical application of light-absorbed gold microparticles followed by exposure to an 800 diode laser. The study said it's improving the inflammatory lesions. We have also important thing, it's home use device like light emitting diode. Also, it's good. It has popularity. Small study published and said it's good efficacy and its safety. FDA approved the thermal clear It's provide pulse of heat, 5 days trial found a great percentage in treatment and treat the lesions. Okay, can we go next? Okay, can we go? If I have time, I can talk about the previous slides. It's about typical treatment as some information. Do I have? Or shall we go to the questions?
Yes, we need to start with the questions actually. So question number 1, who gets the acne and how come some people get it more often?
Me?
Okay, I'll repeat the first question. Who gets the acne and how come some people get it more often?
Okay, we talked about it's about multiple reasons. It's about we say about it. It's more frequent in adolescents. So maybe it's about the also diet. It's about genetic reason. Yeah, I heard you. Yeah, it's a multiple reasons. So no, but just because I have echo, that's why.
Okay. Next question. What are core factors affecting acne?
What are the 4 factors? It's first the bacteria and the keratinocyte, the follicle keratin that we have it like dead skin or the have extract in our skin. Also, we say the bacteria, inflammation, and also the sebum that comes from sebaceous gland. This is the 4 main factor. It causes the acne. Also, we have associated factor, but this is the 4 main ones.
Next question. When should I see a dermatologist for acne treatment?
Okay. Do we have more questions?
When should I see a dermatologist for acne treatment?
Okay, this is an important question. When to come to the clinic? Because we cannot wait until scar comes, then we go to the doctor. No, we should come before that. If I have once I see the inflammation acne, the red acne, I should see the doctor. Or if I have like a lot of comedones, because comedones is like time bombs to the inflamed acne, and inflamed acne leads to scar. So better to see the doctor if I have large area of inflamed acne or multiple inflamed acne or a lot of comedones involved like face or back or breast. And even when in women they might have a wrong skincare, they don't know the reason. So if they have a multiple here in this area also, it's better to see the dermatologist.
Next question. Are there any side effects to certain treatments and how can we manage them?
Yeah, there is a lot of side effects, especially the isotretinoin. We can manage through following with the doctor. But first, we have to choose the patient. Because like contraceptive, it's only for females, and we have to take into consideration the cardiovascular problem. Spironolactone also, it has a problem. It cannot be tolerated by all patients. So yeah, we have side effects, but we can manage by doses, by follow up with a doctor, by even topical sometimes have irritated our skin within a few days. So we can go also to the doctor for the next time and he can change this.
What ingredients would we look for in an acne treatment and why?
Okay, also good question. If we have distillations or greasy skin, or this is the more have high risk for the or if we put makeup for long time of we have start with comedons. It's better to go with a cleanser that doesn't need to prescription by the doctor. We have to focus on salicylic acid. We have to focus on azelaic acid and benzoyl peroxide. And we have salicylic acid and benzoyl peroxide are available in solutions and in creams with low percentage. Always start with low percentage and do it frequently, gentle application. Also can be good. Also, it can be taken without prescription, but also we should start with low concentration. But I recommend more with sulfur and salicylic acid and benzoyl peroxide and azelaic acid. We have alpha-hydroxy acid for sure.
Last question. What's the most dangerous chemical used in a face cream that causes acne?
Excuse me?
What is the most dangerous chemical used in a face cream that causes acne?
Chemical cause acne?
Facial cream. Yeah, this is from our business. I mean, if there is any chemical used in the facial cream that can cause acne, which one is the most dangerous?
Yeah, generally oily chemical or thick products are oily because it's a block and cause the pores and block the follicles. So this is lead to acne. So we don't need to put like moisturizer or thick makeup, or we shouldn't leave it for a long time. So that's what I recommend.
Thank you, Dr. Raghda. It was a pleasure having you with us today. We would like to express our sincere appreciation to our speakers for supporting the conference and making it a huge success. I want to add that over the day we had more than 1,000 global conference visitors, making this event very successful. It was not possible without your support, and we would like to thank our local and international media partners, Marhaba, I Love Qatar, CN Media, Kind Congress, Medflix, MedTube, Medicaspace, and Medidzi. Next year, we'll have the Qatar Dermatology and Cosmetology 2023 as a hybrid event, so stay tuned for the updates. On behalf of Next Fairs and ZMZ event, we thank you again and look forward to your support for our future events.